Good afternoon, everyone, and good morning to those joining from various locations where it's morning. Welcome to today's webinar. We'll be looking at this topic, critical care in Sub-Saharan Africa, a necessity or an expensive luxury. I'm Nana Sefa. I'll be your moderator for today. I'm an emergency medicine critical care provider at the Washington Hospital Center in Washington, D.C. We have various panelists and a chair who will be talking to us today. A few housekeeping points. One, this webinar is being recorded and will be shared later by the Global Health Network. Due to the number of participants in the videos, microphones are automatically disabled till we get to the Q&A section when they may be activated. If you want to interact with the host on any technical issues, use the chat function, which would alert them and they will help you resolve that. And if you have questions for the panelists, use the Q&A session and we'll do our best to answer almost all, if not everything for you. And the ones that are left at the end of the session, we'll get to you in writing later. You can use closed caption to adjust the language to your preference if you want something other than English. In terms of our panelists, we have Professor Ernest Aniteye, who will be our chair for today. He's a faculty with the University of Ghana Medical School and works at the National Cardiothoracic Center as an intensivist. Myself, I'm the moderator. We have three speakers, Dr. Charlyne Kilba, who is a pediatric intensivist at the Greater Accra Regional Hospital, Dr. Christian Owu, who is an intensivist and anesthesiologist at the University of Ghana Medical Center and Korle Bu Teaching Hospitals. And we have Moses Sian Frimpong, who is an intensivist and anesthesiologist at the Komfo-Anokye Teaching Hospital and with the Directorate of Anesthesia and Intensive Care at the same hospital. So for our agenda today, we are going through the welcome and housekeeping stuff now, and this will be followed by a note from our chairman, Dr. Professor Ernest Aniteye, and then we'll have our first presenter, Dr. Kilba, talk to us about critical care in the context of universal health coverage. Our second presenter will discuss critical care burden and human resource deficits in Sub-Saharan Africa. And our third presenter will enlighten us about postgraduate training and critical care society's role in bridging the human resource gap. We'll have some time for Q&A session and a discussion, and we'll be closed by our chairman. So we have registrants joining us from across the globe, as you can see in this map. Yes, predominantly from Ghana, but not limited to Ghana. We have people from all parts of Africa, Middle East, Australia, and Alaska. So we cut across, well represented, and I'm sure the issues we are going to highlight here are not unique to Ghana and are not necessarily unique to low and middle income settings, but cut across. Thank you all for registering and for joining us today. I'll hand over to our chairperson for an introductory word.
Right, so thank you very much, Nana. It's a pleasure to be the chair for this webinar on critical care medicine this afternoon. For the attendees who are not so versed in critical care, it is a term that is actually used to encompass intensive care, intensive therapy, high dependency units, and also critical care is needed if a patient needs specialized monitoring, treatment, or attention. For example, after routine complex surgery or if the patient has a life-threatening illness. But then if I actually look at it, I saw a definition by Martin Christensen in 2023 when he published it in the International Journal of Nursing Sciences. He said that critical care is the application of advanced medical technology administered by specialist healthcare professionals to alleviate the inherent physio-psychosocial complications associated with critical illness while treating the underlying disease process. I think I like that. It's a lot more encompassing. But then the critical care specialist is not only involved with looking after the critically ill patients. They would do that, but they also do health promotion and have some preventive functions as well. They treat and rehabilitate patients. They comfort and have palliative measures as well. They teach, they do research, and also help with professional development. And last but not the least, they collaborate. They are leaders, and they're also very good with organization. The COVID-19 pandemic revealed the inadequacies that exist in many critical care centers in hospitals in Ghana and around the African continent. And I think a research was spearheaded by Professor Bickard from Cape Town, which looked at patient care and outcomes for patients with COVID-19 infection admitted to African high care or intensive care units, which is the ACOS trial. And after the data had been analyzed, they made some interpretation. One, the mortality rates for most of our patients was almost about 50%, 48.7. They also found out that the increased mortality was associated with insufficient critical care resources. And one of the things they said, there are very, very few intensivists in Africa. Now in Ghana, the Ministry of Health is proliferating a lot of new hospitals which have intensive care units attached to them. And then these new hospitals that are being constructed have little provision for planning for human material and financial resources. The Ghana College of Physicians and Surgeons have been training critical care physicians for a couple of years now. And I think the Faculty of Child Health is also going to start a program if everything goes on by the third quarter of this year. Critical care is a teamwork, and we use a lot of critical care nurses. I think we have a program in Ghana that has been running for almost 15 to 20 years. The number of nurses that we have trained, 70% have departed, over 1,000.
No, I think he was probably about to wrap up, so we can move on and he can add the rest of his comments to the closing remarks when we get to that point. So as Dr. Aniteye was highlighting, critical illness is a major component of disease processes in various specialties across the house of medicine. And low middle income countries in general have a scarcity of the human resource, but we have a high burden of disease that makes it daunting in the fact that we have a disproportionate number of high percentage of critical ill patients, whereas having limited resource, both human and other resources to take care of these. And today, we are going to highlight some of these things, hopefully propose some solutions. We will move on to our first presenter, Dr. Charlyne Kilba. Dr. Kilba is a pediatric intensivist and a fellow of the Ghana College of Physicians and Surgeons. She mainly clinically is based at the Greater Accra Regional Hospital, and she'll be talking to us today about critical care in the context of universal healthcare coverage. Dr. Kilba, you can move on from here.
Thank you very much for the introduction. Okay, so the background to this. In 2019, there was a study by the a publication by Disease Control Priorities Project that estimated that more than a half of deaths and a third of disability in low and middle income countries could be addressed by effective emergency care. And injuries alone killed about 4.4 million people around the world. And that constituted about 8% of deaths. Now, if you consider that nearly 90% of these deaths are taking place in low and middle income countries, that highlights the fact that something needs to be done, and that is why we are having this discussion today. There are obviously major differences in availability and the quality of emergency and critical care services between countries at different economic levels, and these directly impact the mortality rates that we are seeing. Next slide, please. Okay, so universal health coverage came about in 2015 when, as part of their the targets set for our sustainable development goals that we hope to achieve by 2030, member countries agreed to also implement universal health coverage in their countries. Now, what is universal health coverage? This means that all people have access to the full range of quality health services they need. And they get this when they need it and where they need it without financial hardship. So they need to get the full range of health services when and where they need it and without financial hardship. I've highlighted those bits because in our setting, those are big challenges. Now, this universal health coverage covers a continuum of essential health services, right from health promotion, treatment, rehabilitation, and palliative care across life's course. Next slide, please. So WHO's recommendation is for health system for countries to reorient their health systems using a primary health care approach. And this is because evidence shows that about 90% of interventions under the universal health coverage can be achieved through an effective primary health care system. And this, if done properly, has the potential to save about 60 million lives per year and increase the global life expectancy by almost 4 years by 2030 if we do achieve universal health coverage for all people. Now, primary health care is essential, and even though we are talking about critical care, we cannot underestimate the importance of primary health care. We all need it. Everybody needs primary health care, whether it is attention to healthy diet and exercise or coordinated prevention or management of diseases. It plays a crucial role and is the bedrock of our healthcare system. Okay. So as we countries across the globe try to implement or roll out universal health coverage, data continue to show that there was still a very high incidence of illness, as I said in the beginning, or mortality, that could be prevented by improved emergency care. And so at the 72nd World Health Assembly in 2019, there was a call for additional efforts globally to strengthen the provision of emergency care as part of the universal health coverage, so as to ensure timely coverage, timely and effective delivery of life-saving healthcare services to those in need and improve their outcomes. Okay, so Ghana has our own roadmap for achieving universal health coverage by 2030. And in this document, we define universal health coverage as all people having access to high-quality health services, irrespective of ability to pay at the point of use. And this is not limited to a level of care. It's supposed to go across the continuum of care. And the goal is to increase access to quality, essential health care and population-based services for all by 2030. And those are the objectives. But from the objectives, you can see that the focus was more skewed towards maternal and child health. Okay. And an increased responsiveness to public health emergencies. Next slide, please. Then came 2020 and COVID-19. Well, began in the latter part of 2019, but really blew up in 2020. And this pandemic revealed the significant gaps in the provision of emergency and critical care globally. And this was much worse in low and middle income countries. Next slide, please. So following that, WHO at the 77th World Health Assembly then highlighted the need to integrate the provision of emergency, critical, and operative care into universal health coverage, because the COVID-19 pandemic exposed the big gaps that existed and the need to quickly tackle those. So this was the aims of this measure, was to ensure that the health needs that cuts across the spectrum of health, not just primary health care, but those who were sick, those who were injured, those who needed surgery, was incorporated into the spectrum of care to enable countries achieve our SDG goals. And if we are able to effectively implement universal health coverage, including the EOC care, then we are likely to be able to make good progress towards achieving 10 of our SDG targets. And then this would also halve overall deaths in low and middle income countries. Next slide. So what does this emergency, critical, and operative care entail? So it's supposed to be an integrated, people-centered service delivery. Okay, that starts right from the primary care level through referral and transportation systems to our referral centers and counter-referral mechanisms, where higher up referral centers, after stabilizing, can also then refer back down the referral tract to lower centers to complete care or for follow-up. It includes rehabilitation as well as palliative care. And the aim of integrating this into primary healthcare coverage is to ensure that severe illness, including sepsis or disease, illnesses from infections or injuries, complications of pregnancy, childbirth, or heart attacks and strokes, which are on the rise in a lot of low middle income countries, the non-communicable diseases would also, complications of these diseases would also be effectively addressed under the primary healthcare program, universal healthcare program, sorry. Next slide. So why are we talking about this? Does primary healthcare have any role to play in the care of severely ill patients? It does, okay, because we realize that in our setting, a lot of critically ill patients are actually managed outside of our typical ICU settings. They are managed on the wards, in emergency rooms, in district hospitals, in health centers. And it is important that along the whole continuum of care, we institute measures that allows for early recognition of patients who are ill or severely ill or at risk of deteriorating, so that the appropriate pre-referral care can be given, the appropriate referral can be given, and the patients will get optimal care. At the primary health care, basic things like rehydration, provision of antibiotics or antimalarials, aborting seizures, providing oxygen can be carried out, and these can change the course of outcome for patients if instituted early. In addition, at the primary care level, there's a lot more community engagement, and this is an opportunity for advocacy and mobilization of community resources towards improving healthcare delivery in our communities. It's also an opportunity for education of the community members on warning signs and the need to seek care early and where to seek care from. So the picture on the right-hand side is a demonstration of the network of practice that is being implemented. Well, we've started implementation in Ghana. And the idea is to link up all healthcare services at the community level to a hub, which will be the healthcare center. So these healthcare centers previously provided very basic care. They literally just treated outpatients or identified emergency signs and referred without necessarily being able to put in any initial measures or significant pre-referral therapy. Now, under this network of practice, these hubs, which are healthcare centers, the hubs are being upgraded. So not all healthcare centers will be the same. So you have the hubs that are elevated to a level that is a little higher than a typical healthcare center, but not somewhere in between that and a district hospital, so that they can provide some essential emergency care before referring. So these hubs are then connected to what is termed the spokes within the facility. So any group that is involved in any way in healthcare delivery within that community is then linked up with the hub. And there's good communication between the hub and the spokes to facilitate referral of patients from the communities. Next slide, please. Now, for this to be effective in finally achieving good outcomes in severely ill patients, it means that there has to be a good referral system so that when these patients are identified, receive their pre-referral treatment, they are transported in a timely manner and in a safe manner, ensuring that there's appropriate treatment during transport to reduce morbidity and mortality. Now, in Ghana, we have the National Ambulance Service. And in addition, in certain districts and regions, they have introduced a tricycle ambulance system to make it easier. First of all, it's more affordable, and it's also easier to traverse some of the terrains in the district and sub-district level. So these are typically used to convey patients from the spokes to the hub and from some hubs to the district hospitals. And then the ambulances come in mostly from district to regional hospitals. So I already explained what the network of practice is doing and how our ambulance service is coming, plays a role in achieving our ECO service. In addition, the government, with the support of partners, has upgraded some regional and tertiary hospitals to be able to provide better emergency cares, and a few more regional hospitals now have ICU facilities, and my colleagues will speak to that in more detail in the subsequent presentations. In addition, like Prof was saying in the beginning, we are investing more in human resource training with more advanced level of training for healthcare workers. Now, most of the, we have the Ghana College, West African College for the Physicians introducing specialty and subspecialty training that would improve human resource capacity in those areas. We have the nursing colleges that are also introducing specialized programs for nurses. Pharmacists are doing the same. And there's a lot going on with regards to human resource training. Next slide, please. Unfortunately, despite the efforts that are being made, we still have quite a lot of challenges. And what are some of these? So some of the bottlenecks that have been identified in the Ghana Health Service document on our universal health coverage are shown in the diagram below. And you can see that funding is the first one that is highlighted there. NHI, as our National Health Insurance Scheme, is the primary driver for healthcare in Ghana. Unfortunately, the reimbursements are slow or not adequate, and healthcare facilities are crippled by the lack of funding in that regard. And also challenges with upgrading health centers with what they need to be able to serve as a hubs. So that also has underlying financial challenges, because you would need money to be able to equip those centers to be able to provide that care within that network of practice. Then stockouts of medication. So it says that there's regular stockout of at least 40% of drugs that are monitored, even at that level within the primary healthcare system. So availability of drugs and essential supplies is a problem, a big problem for us. In addition to that, we still have, despite the NHIS, as you climb higher up the ladder of care to regional hospitals and tertiary facilities, there tends to be a lot more out-of-pocket payments. Therefore, we are not able to meet that aim of not impoverishing citizens when they seek healthcare, our patients when they seek healthcare. And we still have limited reach in terms of transportation of ill patients with regards to the ambulance service. And palliative and rehabilitative care is almost non-existent in most parts of the country. Then to add to all of this is the big impact brain drain is having on our healthcare workforce. And Prof alluded to that in the beginning, but in most of these, in specialized centers, as you climb higher up the hill, healthcare workers who have been trained and have special skills are the ones that we are losing the most. Okay, so what is the way forward? Well, we would have to update in Ghana, and I guess in many other developing countries who have not yet updated their universal health coverage to include the emergency, critical, and operative care would need to do that. And we haven't seen that yet done in Ghana. We need to strengthen our healthcare systems and improve health infrastructure to actually be able to translate what we have in policy into practice. We need increased training and capacity building for healthcare professionals, improved referral systems and community engagement. And we need to be able to leverage technology and partnerships in this day and age to help to improve critical care services, most of which is occurring outside of our standard intensive care units. And then, of course, we need to increase research and data collection to inform policy and decision making. Next slide, please. So in conclusion, emergency, critical, and operative care is an essential component of the universal health coverage. And without integrating it into our universal health coverage, we are unlikely to be able to achieve SDG goals related to health. Low resource settings face significant challenges in providing critical care services. But it is only a coordinated and strategic approach to the entire continuum of care with regards to emergency, critical, and operative care that would guarantee effective care for people with high burden conditions such as injury, sepsis, complications of pregnancy, or even malignancies that require surgical interventions and more intensive care. Emergency care, critical care, and operative care services are highly interdependent. And so in all contexts, we should try and tackle them together because it's all really interlinked. Thank you very much.
Thank you, Dr. Kilba, for your presentation. And you highlight an important factor. In 1978, when the Almata Declaration was adopted and promotion of primary health care became a thing, critical care and emergency care were both in their infancy. Fast forward some 40-something years, it has become clear that all the primary care investments could be put into a person only to lose them to a preventable disease condition that could have been avoided or treated expeditiously if we had a full spectrum of care, which is why in February 2023, WHO adopted emergency, critical care, and operative care as part of the Universal Health Care Declaration as a means to realize that till we look at the full spectrum of care, a patchwork of primary care alone is not enough. And I think as you've highlighted, various nations will need to adapt their universal healthcare policies to capture that spectrum and ensure that we are not losing all the investment we make in, for instance, an example I used to give is you can immunize everybody, prevent all these diseases, and then a 25-year-old lady is lost to puerperal sepsis, which could have been treated if identified at the primary care environment and started on antibiotics before the referral, rather than wait till refer them, don't initiate treatment, and then by the time they get to the referral center, they are so sick, we lose them. So this is definitely highlighting our issues, and I think we can get there.
Absolutely. And I think now the focus is to develop a global strategy and action plan. So WHO is leading that, and hopefully that comes out it's supposed to guide us from 2026 to 2035. So hopefully there will be some guide for countries to be able to use to fashion our own strategy. Thank you.
Thank you very much. Okay, let's get, so our next presenter will be Dr. Christian Owu, who is a senior lecturer, Department of Anesthesia, University of Ghana Medical Center in Kolebu Teaching Hospital. He's a fellow with the Ghana College of Physicians and Surgeons and lead faculty for the Fellowship of Critical Care Medicine with the Ghana College. He has consultancies with the WHO and various other organizations. And today he'll be discussing for us the role of human resource deficit in critical care. So Dr. Owu, you can take over from here.
Thank you, Nana. I hope you can hear me.
We can hear you and see you clearly.
Thank you very much. And my regards to Charlyne and to Prof. Aniteye. They basically has linked most of what I am going to talk about. And I think that this is a conversation that is never too early. It is a conversation that we should have started a long time ago, and we definitely should be having now. The requirements or the tools or resources for this conversation is available in our environment, so to speak, in Sub-Saharan Africa. So I do not have any conflict of interest to declare. I would say that I worked with WHO when the resolution on echo care was passed, and our team was strongly involved in that. So I have quite a good grasp of what is in that paper. What is important is actually that paper, that resolution by the World Health Assembly originated from Africa and other countries in the LMIC, as against most previous ones. This is my outline. A lot of my story is going to be told by pictures. They said a picture can tell 1,000, can basically speak much more louder. And the first question I ask myself is basically what we asking everybody: is quality critical care an expensive luxury? And this is a picture of a number of interchanges in our country, in Accra. And this is at the point where this was completed. Or is it a clear necessity? It is important to bear this in mind. And I've used these pictures because I'll come back to these pictures later on. So for introduction, Dr. Kilba talked a little bit about the introduction of echo care. And what I've done here is put a bit of snippets of the echo care, the resolution by the World Health Assembly on this screen. The integrated emergency, critical, and operative care for universal health coverage and protection from health emergencies. A few of the things I have put there, it's just I'll quickly read the bottom part, that noting that emergency, critical, and operative care services are an integral part of a comprehensive primary health care approach and are essential to ensure that the health needs of people are met across the life course without undue delay. In another part of that document, it acknowledged further sustainable development and the role this plays not only in our cities, but in human settlements with respect to previous sustainable development goals, 11, 3, 16, that had been already there, but had not addressed this. It also recalled the resolutions, other resolutions, multiple of them, that had been passed by the World Health Assembly, but did not have a emergency, critical, and operative care integrated in it, and then insisted that this actually should be fundamental because that was identified in them. It went ahead to make urgent calls to member states, including our countries in Sub-Saharan Africa. And there are 12 urgent calls that were made to basically focus on. And among those is to create national policies for sustainable funding, effective governance, including coordination and regulation of public and private health sector, and universal access to the need-based emergency critical and operative care. It insists that our national policies should include emergency critical operative care with their associated rehabilitative services, and as appropriate to conduct WHO emergency critical and operative care system assessments. And these tools do exist. The other thing it did was to make requests of the Director General of the World Health Assembly and ask that members, and there are 12 urgent requests that were included. I just highlighted the last two of these urgent requests to support member states to identify innovative and sustainable financing mechanisms to ensure access to essential emergency, critical, and operative care services. And then gave an ultimatum to report on progress in the implementation of this resolution to the Health Assembly in 2025, 2027, and 2029. The first report is less than a year from now. The question is, has any of this been implemented? Have we seen evidences of this in our countries in Sub-Saharan Africa? When this resolution was being passed, a number of global acute care advocates came together to try to put an impetus on implementation of this. And I'm glad to say that I was one of these guys, which cut across every geographical area in the world and had a very good representation from Sub-Saharan Africa or those practicing in Sub-Saharan Africa. And this was published, this was the first publication of an editorial in the intensive care medicine, which I actually lead authored. And that was titled the World Health Assembly Resolution on Integrated Emergency, Critical, and Operative Care for Universal Health Coverage and Protection from Health Emergencies, a golden opportunity to attenuate the global burden of acute and critical care. We went ahead to make recommendations to ensure success of the resolution, which included assessment of the burden of echo-related acute illness, including needs assessment at national facility and pre-hospital levels. We recommended that we build strategies to develop and expand eco-human resources to scale up capacity at all levels, similar to what Dr. Kilba mentioned. We insisted that there was the need for rapid expansion of oxygen delivery capacity as described in related World Health Assembly resolutions to identify and make available high-impact diagnostic and therapeutic resources in echo care, implement low-cost, high-yield echo services for all patients to ensure equity and population impacts, and develop programs to progressively improve on the quality. And finally, to establish data collection systems, because one of the things we recognized was the paucity of data, especially from Sub-Saharan Africa and other low middle-income countries. So I'm not going to spend too much time on universal health coverage. I think Dr. Kilba did a good service to it. What I just wanted to highlight is that global health is about people and the systems needed to support people to live healthy lives. It is a systems and delivery problem, not just a disease problem. And this was nicely coined by the current Director General of WHO when he said universal health coverage and health security are two sides of the same coin. So what I highlighted here is and I've labeled it Ghana and African burden of diseases, communicable and non-communicable diseases and injuries, are actually from the global So let me say a big apology to everyone. You just saw one of the challenges in delivering critical care in Sub-Saharan Africa. I'd had to make a quick drive of about 25 minutes to relocate to be able to complete this. But thank you all for the opportunity to finish up. I believe this is around where I dropped off, where I was looking at the global burden of diseases. So
Yes.
I'll go quite fast. As I said, most of my story will be told by pictures. So when you look at the global burden of diseases, and then you're looking at what I've done is moved that from the previous slide, which looked at the three combined. And whenever we look at the three combined, we have that notion of the low middle income countries, especially Sub-Saharan African countries, are bedeviled by infectious diseases, but we do not have a lot of non-communicables and injuries. And that is a lie. So as you can see, where I have segregated this into the three different, Africa actually, both for infectious diseases, non-communicable diseases, and those related to injuries, has either similar or way worse burden than every other geographical part of the world. And therefore, that puts our discussion in context. And one of the contextualization of this was the Lancet Global Health Commission in 2015. That's Dr. Kilba also referred to at some point. And part of what that highlighted is the poor or inadequate care that is common across conditions and settings in our region. Today, quality is actually a bigger problem than access. Yes, we have made progress in the last 2 or 3 decades, especially in infectious diseases, but access is a bigger issue. Quality is a bigger issue than access in most places now. High quality health systems could save over 8 million lives each year in low middle income countries, and over 85% of these are in Sub-Saharan Africa. And new research is crucial for transformation from low to high quality health system. I need to emphasize that high quality health system is not synonymous with expensive health system. And I am happy Nana also mentioned that, and so did Prof. Aniteye and then Dr. Sian Frimpong. We need to get to the point that we realize that we can actually have high quality health systems and high quality critical care in our environment, which may not be the same as what it is in the high income countries. But what is critical illness? Prof. Aniteye gave a very nice definition. This is another definition I want to remind you of. It's a state of ill health with vital organ dysfunction, a high risk of imminent death if care is not provided. I must have a potential for reversibility. That separates this from terminal diseases. And as Nana said, ICUs and critical care areas should not be the final common pathway for all mortalities. As you can see, that includes all the different burdens of disease that I have already mentioned. We need to be very aware about the differentiation between critical illness and the disease diagnosis that we are very used to and were taught as we progress through medical school, through nursing training colleges and other health training, professional training centers. So we are focused on what we call the critical illness syndromes, which basically any one of the disease diagnoses can result in. We are focused in what is causing hypoxia, what is causing shock, unconsciousness, and a blocked airway. So the burden of critical illness globally has, a lot of it has already been mentioned, about 11 million annual deaths from sepsis, which is a cardinal part of critical illness. Almost about 45 million adult critical illness cases annually, and in-hospital prevalence of critical illness of up to 18%. But let me remind you that most of these data are coming from places where there are better access to care. So when we say that the mortality of critical illness is 15 to 30%, we are aware that this is far worse in Sub-Saharan Africa. So the data we're talking about, the numbers we just spewed out, is an underestimation. It does not usually include actual data from most low middle income countries, and of course, most of which are Sub-Saharan African countries. So the ESOS study, Prof. Aniteye referred to, and in addition to the ACOS and ESOS2, ESOS PEDS, and that is a collaboration between within Africa by perioperative physicians and other minded colleagues in the perioperative environment. And that demonstrated that we have higher mortality in the perioperative for a perioperative outcome compared to other geographical areas. But then this is the ACOS study, Prof. Aniteye referred to, of which the two of us were co-leads for Ghana. And the fact that when other places were reporting mortality of between 20 to 30% for their COVID critical illness, in Africa, we were almost 50%. And these were actually from 10 African countries, over 64, about 64 hospitals, which came from most of our best hospitals. This is not even a true representation of what happened in our continent. And it basically revealed 11 to 23 excess deaths per 100 patients compared to other global averages. It also showed that there was insufficient critical care resources. It showed that only 1 in 2 critical care referrals to high centers were admitted, and access to interventions were between 7 to 14 times less than what was required by standards. Yes, we may say that that was COVID, but we were not better off before COVID, and we actually worse off after COVID. This was one of the things one of the audits we did early in the pandemic, where at the very beginning of the pandemic, within 2 months, we realized that we were, most of our patients who had severe or critical COVID-19 were dying. And when we looked at that even more closer, most of these deaths were those who were outside critical care admission. So out of the case fatality rate of 54%, 92% of the case fatality rate for those who were outside critical care. Then there was a lot of repurposing and introduction of interventions to increase critical care capacity throughout Ghana. And among the things that we looked at was what the results we had from the ACOS studies, which involved 2 centers from Ghana, Korle Bu Teaching Hospital and UGMC. And then our mortality had crashed from the initial mortality of over 50% to 20.2% for our country-specific mortality. When we introduced the Infectious Disease Center intensive care, within the next 1 year, our mortality actually dropped to 14.5%. Similar and to some extent better than most places in the developed world. And this was just a testimony of what could happen if we had similar inputs or interventions into critical care in Sub-Saharan Africa. In COVID, about 20% of our patients were critically ill. A lot of those died. We were lucky that majority of our patients were not critically ill. But where are the critically ill patients in our environments? They are not in the intensive care units. They cut across the continuum of our health system. It occurs throughout the health system. In actual fact, studies show that about 97% of critically ill patients in Africa from a study in Malawi were in the general wards. And it's not a lot better, even in the developed countries, as the study from Sweden showed that about 94% of their critically ill patients were in general wards. The difference is the quality of care even those patients in the general wards are getting. So we asked, what is the burden of critical illness in Sub-Saharan Africa? And we are in the process of answering that question. So we came together, about 181 hospitals from over 40 countries in Africa, to basically start this study known as the African Critical Illness Outcome Study, ACIOS. That's ran from September to November of last year, and is currently being analyzed. But even some of us were already seeing what that data was going to be telling us. But we will wait for the first preprints of this data, because that will be the very first African comprehensive burden of critical illness. Why? Because this did not only look at our patients in the ICU, it was hospital-wide. Every admission on the day that we were recruiting in our hospitals who were 18 years and above were recruited into these studies, and we followed them up for up to 7 days. 18 hospitals from Ghana, including teaching hospitals and Ghana Health Service facilities, including some district hospitals, were involved in this. As I said, a much bigger study. Over 21,000 adult patients on admission in Africa were involved in this study. We will see what this study will tell us, but we have a few other studies that have told us that that our capacity to deal with this are very low, and that takes us to critical care capacity in our country, in our continent. We say critical care is identification, monitoring, and treatment of patients with critical illness throughout the initial and sustained support of vital organ function. Critical care is not the same as intensive care. It goes way beyond intensive care. The most important part of it for most of these patients, when we have them, we look at the critical care. But most of these patients are also receiving other cares that are given in the hospital, including definitive care, other cares like nursing, physiotherapy, and psychosocial care, and of course, the hotel care. Critical care is needed for all critically ill patients. They also require this other care. So if you look at this diagram I put here, there are emergency patients who are critically ill patients. There are all intensive care patients are critically ill. And there are other acutely ill patients. And that was why it was important that the World Health Assembly did pass the resolution to integrate these different problems and to have a frontal approach to dealing with it. We've already mentioned where these patients are, depending on the setting. The level of critical care may be university level, advanced critical care, as you can see on one of the pictures on the left, or it could be district level, as you can still see in the one at the bottom. I have emphasized that it's not the same as intensive care, and that is part of the reason why a lot of critically ill patients in our general wards are not receiving critical care, because they are not recognized as being critically ill. So this is just a picture to show the different level of cares, and situated at just the bottom there is.
You know, sometimes thunder can strike twice to the same person.
All right. Before I was interrupted by the light off again. So this is critical care delivery across. This was just published last year by a few of our colleagues that looked at where are we reporting from. And then even when we said low middle income countries, majority of what is in Africa, there was no report from. It was just from about 17 of the low middle income countries, majority of it from India and Pakistan. So this is the critical care capacity in Africa pre-COVID. As I said, it's not much better. If you look at our critical care beds, the ideal should be about 11.5 critical care beds per 100,000. In most places in Africa, it ranges from 0.3 to 1.5. Basically about less than 1/10 of what it is in ideal. Our nursing to patient ratio was definitely less than 1:2, 1:3. In some places, 1:10 patient, as against the ideal 1:1. And majority of critical care in Africa is provided by anesthesia providers. And even that is as low as just about 1 in 100,000 compared to 14 to 100,000 in the European Union. The diagram you see on the right is actually the distribution even for Africa. And as you can see, if you take out South Africa and then some of the places in Northern Africa, majority of the countries in Sub-Saharan Africa is basically way below. There are loads of them which has basically zero. So this was from our country. Again, what facilities are providing critical care. And what I just want to highlight is the fact that even when we say that our facilities are providing critical care, the full percentage of our in the private sector. So this was the picture I said earlier on. The critical care capacity challenges in Sub-Saharan Africa looks like this giant. Most patients are, in our wards, not receiving critical care and are trying to move into intensive care units. And we know what that means, that they're not going to get anywhere in such a traffic. So is the solution building more of these flyovers, huge interchanges to solving that traffic problem? And yes, we have built some of those in the form of intensive care. Sorry, actually, like these ones. But most of these beds still remain unoccupied because of lack of human resource capacity to run them. And then other resources like financing. Most of our patients cannot even afford the care for a day in ICU, let alone for those who have to spend more than a week. So is quality critical care an expensive luxury, as we asked at the beginning? Or is it a clear necessity? But the funny thing in Sub-Saharan Africa is that actually it may be two sides of the same coin. The funny thing is that the picture that you see on the left, which is very beautiful and that looks luxurious, is the same picture you see on your right with jam pack. So we have intensive care units where in some of our teaching hospitals and our regional hospitals, with our patients still jam-packed underneath in our wards. And therefore, we still have a big problem. So one of the things we looked at during COVID, and this was a paper that I wrote for the WHO, tackling surges in severe COVID-19 in Africa, was that we needed to look for a way forward for critical care in Sub-Saharan Africa. And there are multiple people in our space now are coming together in advocacy. So this is one paper that we wrote, which has actually been accepted and promoted by the International Federation of Emergency Medicine and the World Federation of Societies of Anesthesiology, which is a white paper on early critical care services in low resource settings. And these papers are not just papers which are coming from the West anymore. These papers have those of us who live and work in our part or in Sub-Saharan Africa involved in putting them together. That includes the recent call to action by some of our colleagues that has also based on the resolution that was passed by the WHA. And among the things that we have highlighted in the call to action is prioritizing critical care, defining the burden of critical care in our environments, implementing essential emergency and critical care, increasing the workforce and specialist training, mandating context-specific research, optimizing government healthcare spend, appropriate expansion of advanced ICU capacity, and advanced critical care outreaching, as well as global advocacy. So the picture you see on the bottom right-hand corner actually looks at different strategies based on the global critical care call to action towards addressing the deficiency or deficit of critical care capacity in Sub-Saharan Africa. We've looked at multiple ways, and these are just basically rehashing what I have mentioned at decongesting the traffic or the gridlock that are basically bedeviling our tertiary and regional hospitals. And I would just make a few comments on a significant paradigm shift, which we called the essential emergency and critical care, which is the most simple first-line form of care for critically ill patients. And we say it is the care that all critically ill patients should receive in all hospitals in the world, and irrespective of their age, gender, diagnosis, or social status. So this is a concept and system innovation, and this brought together about 269 critical care experts, acute care experts, to look at what should be made essential, what should we refer as essential, and that basically has been recognized by WHO, the World Bank Group, and in multiple other entities in Africa, including the World Federation of Societies on Anesthesiology and International Federation of Emergency Medicine. And we are actually discussing this in the All African Anesthesiologists Congress in Johannesburg in 2 months' time again. So EECC is essentialness in critical care. It is looking at what are those low costs feasible to deliver effectively addressing the important health threats in our population. Those care that we can provide even in our general wards. It looks at not just the resources with respect to clinical resources, but hospital readiness resources. And as I mentioned, identifying the critically ill patients, but looking at clinical processes as well as hospital readiness processes that we can use to address that. I will not spend too much time on this because I believe that there would be other avenues to address ECC concepts. So I would gradually just bring this to an end by basically saying that there are a lot of consensus in our sub-region, in the Sub-Saharan African countries at the moment, but we need to work together. We need to work cohesively, and we need to work integratedly, because we are the most affected by the disease, by critical illness. We can actually make sure that we are able to address critical care, and it can become a priority to the health systems in our part of the world, just as it could be for globally. And some of these are basically picture galleries addressing some of the examples, practical examples that we addressed during COVID-19 and afterwards in trying to address this, like repurposing and outreaching of critical care while we developed the critical care human resource capacity alongside. If we wait to develop the critical care human resources alone first, we'll always lose them because they will not have any place to work and will not have any motivation. It includes telemedicine and appropriate use of technology and AI. It includes infrastructure development, but it also includes networking and then communities of practice networking to support people. It includes going down to our districts and provinces to identify where we could actually look after critically ill patients and the human resources that already exist in their environment to upgrade them. That means the ward nurses, like in the pediatric wards and the obstetric wards and surgical wards in my hospital at the moment, who have had to come and have an 8 weeks training in the intensive care unit, and for which we have basically put in monitored beds in every one of their wards. That would then help the gridlock and the traffic that flows towards the intensive care units. So in conclusion, I believe that it is obvious that the burden of critical illness in Sub-Saharan Africa is the worst anywhere globally, and is there, and it's getting worse by the day. The human resource capacity is lower than anywhere else, but we can work together to make, to have innovative implementation strategies to achieve the universal health coverage for our patients. We cannot say that he who is down fears no fall. In actual fact, that is a reckless excuse for doing nothing, because he that is down in a stampede or an earthquake may not just fear no fall. He would have to fear being trampled upon or being buried alive. And I believe that such a meeting gives us the opportunity to put our heads together, but then, more importantly, to work together towards addressing this. Thank you.
Thank you, Dr. Wu, for persevering despite the challenges. You still came back twice to finish, and kudos to you. It highlights the need that sometimes in critical care we may be hit once or twice, but we need to persevere. And as we have challenges, we should still keep pushing through it. Thank you very much for highlighting this for us. So Dr. Moses Sian Frimpong will be our third presenter. He's an intensivist and anesthesiologist at the Confanochi Teaching Hospital. He is a member of the Kumasi Center for Collaborative Research and leads the residency program in anesthesia and critical care at the Confanochi Teaching Hospital. We will have Dr. Frimpong start his presentation on the role of postgraduate training and critical care societies in bridging the human resource gap or deficit.
Okay, thank you, Nana, for the introduction. Thanks once again, Nana, for the introduction. Like you said, the topic I'm presenting on is the role of postgraduate training and critical care societies in bridging the gap in the human resources in the area of critical care. And I thank the first two presenters for highlighting the burden, and Dr. Wu had just even significantly made the point that there's some deficits. And what are some of the ways to bridge this gap? That's what my presentation is about. I don't have any conflict of interest to declare, so I'll proceed. This will be the order of my presentation. I'll give a brief introduction. We'll look at the training of intensive care medicine physicians. Is there a need for training at all? And what training models are available? Having done that, we'll look at the role of postgraduate training institutions in helping to bridge the gap. And then we look at how the professional societies like Ghana, the Critical Care Society of Ghana, of which I'm a member, would help in bridging the gap, and then we will leave. So just by way of brief introduction, critical care, the doctors or the medical specialists involved in the care, in leading the care, are the intensivists. And these doctors have specialized in treating patients with potential present or recent life-threatening organ system dysfunction or failure. Now, if you understand that they are dealing with the most acutely ill cohort of patients, then it's imperative that they have a very high level of training to equip them with the requisite skill to deal with the task. And it goes without saying that adequate training is very essential in helping to manage these cohorts of patients. Ultimately, if you have better doctors, then you have better care for these patients. What has been happening when it comes to training of physicians in intensive care medicine? It's one area that the practice is varied in terms of training accreditation, and it's a rapidly changing model, some of which I'll highlight going forward. But if you recognize the global village that we live in modern times, then harmonization among the different countries is necessary, because from time to time you are called to help in another country, or there's a job opportunity somewhere. So harmonization in terms of some basic content in the level of training is required for physicians across the globe, and Sub-Saharan Africa in particular, to be able to function optimally. Well, before we even commit resources into training these specialized group of healthcare practitioners, we have to first determine if there's a need for training at all, the need to invest resources in this group of physicians. And a systematic review was done by Peter Pronovost et al. In looking at the impact of physician staffing patterns and the clinical outcomes. Essentially, they looked at the outcomes comparing areas where you have doctors with focus or specialization in critical care management as against the other group of doctors who don't really necessarily have focus in intensive care or critical care management. And they found that the presence of intensivists is associated with significant reduction in the mean stay and in hospital mortality. So it goes to point to the fact that it's imperative to invest in the training of these cohort of physicians who will have focus in managing the critically ill, and that has been shown to improve outcomes. So which institutions are responsible for postgraduate training? Like we said, when it comes to training and accreditation, the models are varied. In some countries, I think the UK, Ghana follows the UK, there are postgraduate colleges, professional colleges that supervises the training of physicians in various medical specialties. In some other countries, especially the Francophone countries in Sub-Saharan Africa, postgraduate training and specialization are linked to the universities. But in countries, in the Anglophone countries and Ghana, when it comes to specialization, the universities don't play a role. They focus on training the undergrads, but postgraduate is for postgraduate college, whereas in some other countries, it is led by the universities. There's also a hybrid where universities partner with postgraduate colleges to train these group of doctors. And then in some countries, you have the societies, which is a pool of these professionals having to put together some curriculum to train physicians at various levels of expertise to handle the critically ill. So in Sub-Saharan Africa, where we've highlighted a serious deficit, we need to look at all these models, what people have done out there, and see which ones to adopt, or whether we need to tweak any of them or merge some of them in a bid to fast track the production of our manpower to bridge the gap that we have. And that's what we are talking about. So the postgraduate colleges, if you come to Sub-Saharan Africa, I think the major postgraduate college is the West African College of Surgeons. But that said, we have some country-specific postgraduate colleges. In Ghana, you have the Ghana College of Physicians and Surgeons. Then our brothers in Nigeria also have their National Postgraduate College, and it sort of cuts across. So there are postgraduate colleges that are leading the training of these professionals. Their key role is to constantly, based on emerging trends, emerging practice, and based on that they identify, to fashion out a curricula for different cadres of physicians, specialists in the care of critically ill. And having done so, they actually also proceed to run these programs and produce these critical care professionals. what are the when it comes to the training, what when the specialization comes, what are the structures that have existed? Generally, you can point out to 3 when it comes to critical care training. The physicians, intensivists, you have a separate medical specialty. In fact, critical care as a specialty in medicine is relatively young compared to the other specialties. And for a long time, it was practiced as maybe an additional specialization by people who have a base specialty. But an emerging trend, which is gaining popularity, is for intensive care medicine or critical care medicine to be a standalone specialty, so that right from the start of postgraduate training, you enroll in critical care or intensive care and go through and exit as such. That is one structure of the training that exists. And like I said, is beginning to gain popularity. So as we think through ways of bridging the gap, it's one of the ways that we can consider. Another way, which is also practiced in some other countries, is as a supra specialty. So these are people who get fully trained in a base specialty. So somebody trained fully in anesthesiology and then takes a year or so training, and some countries will call that fellowships, so that they practice critical care medicine. So that's the supra specialty concept. Then we have the subspecialty concept, where you may start with a base specialty. And let me highlight that the Ghana colleges now, for some years now, have been training critical care medicine. And West African College, we are aware that there's been a lot of discussions to start critical care training. And one of the models we hear they are considering, for instance, is the supra specialty model, where existing already trained fellows in the college will have an option of having maybe a year additional training in critical care medicine and pass as intensivists. Another model that they're also considering is, whilst you're having the regular training in your base specialty, at some point in the maybe last 2-3 years of your life, can you rather focus in the area of critical care? Then you come out as an intensivist. So those are the 3 structures or models that of training that we have currently across the globe. The UK for a long time was doing more of the subspecialty training, but in 2010, the GMC and their postgraduate colleges, for instance, have developed curriculum. And in the UK now, they are phasing out the subspecialty gradually, and there's now opportunity for standalone training. And across Europe, you have these varied models ongoing. Countries like Spain, Switzerland, like I said, UK, and a few other countries have joined, have the standalone critical care specialty, because they believe that that would be a good way to fast track the training of physicians in critical care. Then about 16 countries in Europe practice the supra specialty, and then about 18 practice subspecialty. So you see that the model is quite varied, okay? And whatever it is, the take-home thing is that these postgraduate colleges have to look at the peculiarities in the sub-region and look at which model to adapt or which combination to adopt. Certainly, the quest to do these things have some obstacles, especially in our part of the world. Like I said, one of the things which I highlighted is the inhomogeneity in the curricula. Again, because of the global nature of our world now, generally it is expected that when you say somebody is an obstetrician, gynecologist, there's some basic level of competence that they should have. And the level of competence that you have is based on the curriculum with which you were trained. So because you have the curricula are not homogeneous, then you have different levels of expertise. And when you are about to start training, it's one of the things that bottleneck that you encounter. You wish to equip your trainees with a certain minimum level of expertise, but the existing capacity that you have in country would not let you achieve that minimum level of training that is required globally. And that would be a reason why training will never start. So a country will desire to train critical care people, but the sort of competencies that they will gain per the facilities and the capacity that they have will not equip the trainees adequately. So they would rather wait until such a time that they have adequate ingredients to churn out critical care physicians. And this will delay the human resource production. Then the ICU, because a lot of, virtually all medical specialties at the end of the disease severity spectrum will find their way in the ICU. And people really have a challenge having that interdisciplinary teamwork. And it's a reason why people don't even want to go into the field. So in some countries, they may have the facilities to train, but people opting to join the training program too becomes a bottleneck. What are some of them? The ICU environment, for instance, is a place for ethical dilemmas when it comes to decisions on care. And in our part of the world where we don't have adequate resources, sometimes you have the painful duty of choosing some patients over the other, and you have to use some criteria. It's a very difficult and emotional field to play in, and a lot of stress on practitioners. Because of these, people don't just want to go into that field to have their peace of mind. And the ICU is the place where you have virtually all the superbugs causing all sorts of troubles. Yes, you may have a superbug in another specialty, all right, but when these superbugs are wreaking havoc, like causing shock, organ system failure, they find themselves in the ICU. And people think that because of the infections in the ICU, some practitioners fear that they will they will contract some of these things. So they will even opt to join the specialty for their own health. And all these things have become impediments for us bridging the gap. How do we then increase practitioners in the light of all these? So collaboration between postgraduate and critical care society. The critical care societies have the fully trained professionals who are practicing, and they have real life experiences and to some extent expertise. But the postgraduate colleges, they have the accreditation to bring or churn out physicians who will be recognized legally. So there has to be a lot of collaboration in this regard. And then we need to determine what model works for the country or the sub-region. It's something that when you want to churn out and bridge the gap, you need a lot of thinking on which model works for you. Then would you need to say that, okay, I only train people to the highest level, or given the yawning gap that is there, I would have different levels of critical care physicians so that at least in a year or two, I get some people out, and then those who start can still continue to the highest level. These are all things that you consider in helping to bridge the gap. Globally, I mean, there's been argument that when you have such wide gap in terms of practitioners, then you have to consider other cadres of work. I'll highlight that. But another thing that we need to decide in the sub-region is going forward, do we need to have a standalone intensive care medicine program, which is like you enroll right from the beginning and exit as such, or you rather look at subspecialty and supra-specialty? Like I said, there's been advocacy for wide gaps to be bridged through nurse-based practice or nurse practitioners. Is this suitable in our region? It's a bit controversial because we've had experiences in other specialties where these options were tried, but in Sub-Saharan Africa, the institutions are not so strong. So sometimes political influences succeed in changing a lot of things. So you have somebody being trained using a curriculum for a certain purpose, and they exit and through political influence will now carry themselves out as a different group of practitioners. So it is controversial, and in our sub-region, maybe this will not be the way to go. And who will coordinate all these? Policymakers, postgraduate training institutions, and then the professional societies. And the recently formed Critical Care Society of Ghana has a role in this. So to sum up, professional societies mainly lead in advocacy, in helping to design and strategize processes that will favor training and accreditation of critical care physicians. Let me conclude with a quote by Castellanos Ortega et al. That scientific societies must impulse and facilitate all those initiatives destined to improve healthcare quality and therefore specialist training. They have the mission of designing strategies and processes that favor training, accreditation, and advisory activities with government authorities. This sums up the task ahead, and I hope that the societies in the sub-region take on this. This is my bibliography. Thank you.
Thank you, Moses, for highlighting this part for us. We're going to get Dr. Owu to come back and finish his session. But before he comes, one thing I want to emphasize is critical care delivery in Africa doesn't need to look like critical care delivery in other parts of the world. We have unique challenges and unique disease conditions, and I think we have an opportunity to design something that perfectly fits us and our resources and our limitations. Yes, the goal is to achieve the level of quality and outcomes as others are achieving, but we don't need to make the same mistakes as they've made. For instance, in the US, there are about 5 or 6 different buckets of obtaining critical care training. The US can have the luxury of doing that. We will not have the luxury of that in Africa. We need to design our training programs not to replicate the mistakes of other people. We should pick the lessons others have made and do that. In the same way, critical care delivery in Africa also needs to be uniquely African. For instance, Moses, you highlight the fact that because of the challenges of having some end-of-life discussions in the ICUs, people don't want to join the specialty. I would posit that some of these discussions, because of the limitation of our critical care beds, these discussions should actually be had before the patients get to the ICU, so that the patients who may not be candidates for critical care don't get to the ICU before we have those discussions. For instance, in the US, I always say sometimes people see the ICU as the final common pathway of death. We don't have as many beds for in ICUs in Ghana to make ICUs common pathway of death. People should have these discussions way before the patients get to the ICU, so that the patients who are not candidates don't come and occupy the bed, and then we are taking it away from them to give to someone else. Those conversations. So we have an opportunity to achieve this, and I think seminars like this and other forums of discussion will create the bottom, it will create a foundation upon which we can build something that is uniquely African, but delivers the same outcomes, if not better, than other places. At this point, there are a few questions in the Q&A which we will work and address. And if you have other questions, you can populate it into the Q&A. At some point, the Global Health Network host folk would unmute people. When you have a question, you can raise your hand and you'll be unmuted and you'll be able to ask your question. As we're waiting for the general questions, we can look at the Q&A part. I think some of the questions have been answered. There are a few questions that are waiting to be answered. I'll give time, and the ones we don't get to, Dr. Wu, I'm sure, can answer the question about the pathway to getting into the intensive care training in Ghana whenever he rejoins. And Moses, can you answer the question about how to become a member of the society?
Yes, so the Critical Care Society of Ghana has been formed and registered. We are about to launch it and roll it out. We are done with the constitution and all that, so we'll give more information going ahead, but it makes provision for different levels of membership so that people with interest in critical care can all be part. We'll soon launch it, so they should watch out.
Mm-hmm. Thank you.
Yeah, so maybe if I can take the pathway of getting into critical care training in Ghana. Currently, the only accredited program is through the Ghana College of Physicians and Surgeons, and you need a base specialty. It's more of a subspecialty training, so you need a base specialty training midway through internal medicine, emergency medicine, and anesthesia, and then you apply to the college and go into critical care. So that's the current one. And like Prof said, I think the pediatricians are also cooking something that they are launching soon. I don't know if Dr. Kilba has more information on that.
I have one question. I hope as we look at getting training and you discuss about the pathways to training, I think we need to start considering the routes of making sure this is truly multidisciplinary. You mentioned 3 specialties, but if somebody were an OBGYN who wanted to do critical care, do they have an option of getting trained?
So currently, no, but like you said, you need to start from somewhere and then expand based on a continuous needs assessment. It's always got to do with the which one can be contained within the limited resources. I'm sure that the chairman likely has been spearheading all these. I'm sure Prof will chip in more as we go on. But at some point, yes, it will be worth considering.
And for the panelists, whilst we are waiting for questions,
I don't know whether the question on how affordable is critical care in Accra has been answered.
Right. Yes, I can give that information, Chris.
Okay.
Right. Okay. So I was the faculty chair of anesthesia for about 4 years, and we started the critical care program after a curriculum was written. We've trained a couple of intensivists, like Moses said. The path we had at that time was that you have a membership in anesthesia, and then 2 years after you do the critical care fellowship program. But then our intake, or the people were taking in, were emergency medicine, pediatrics if they wanted medicine. We were a bit worried about obs and gynae and surgery. Surgery will be easy. I have nothing against obs and gynae, but looking at the way we are now seeing that about 60–70% of our admissions into our ICUs are from obstetrics, I think we should look at it. I think it is something that we should look at seriously. And I think Charlyne would mention something about their pediatric fellowship. You know, now we are now saying that somebody who wants to do intensive care can start right from the beginning. They will write a membership exam, but they know that at the end they are doing critical care. It's so nice, a 5-year straight program. That is what the Ghana College is asking to be done. We haven't looked at the super specialization yet, but I think the pediatricians are actually looking at that. We want to budget on their program so that if we have an anesthetist who wants to do pediatric intensive care, why shouldn't they be allowed? So Charlyne can maybe contribute a little bit to that. I think we should open to the other specialties, and I think very rapidly as well. Thank you.
Thank you very much, Prof. Aniteye. So we are just in the process of finalizing the pediatric emergency and critical care curriculum. So we have merged the two. We're doing the program is going to be emergency and critical care, and you can join. It's open to pediatricians, emergency physicians, and anesthetists for now. Those are the three we're starting with. The program hasn't started yet. We are finalizing the curriculum has just been finalized. We're hoping to have our first intake maybe towards the end of the year or early next year. So that's where we are with regards to pediatrics. Thank you.
Yes, as we discuss all this, I will always say that we need to find the quickest means to get as many people through training so we have the human resource. So anything that could be hindrances and roadblocks, we all need to sort of collaborate and work together to take those down, and let's get people trained. And hopefully, as Dr. Wu has highlighted, the work is a lot and we need more people to do it. So anyway, so having Dr. Aniteye here, having Dr. Kilba here, we have people in high places who can talk and open doors for people who need to go through. Thank you very much.
I have a question.
Go ahead, please.
Nana,
Oh,
can you go ahead
okay.
with his question, and then
Okay.
I can add something to you.
Okay. My name is Rodwell Gundo from Malawi. Thanks so much to all the presenters, and I like the concept of the essential emergency and critical care, because sometimes we lose patients just because we are unable to identify critical illness and also the failure to implement the basic emergency care. So I just want to find out from Dr. Wo whether you've done any study to explore the readiness of our facilities to implement this new concept. It could be in Ghana or any other African country. Thank you.
So thank you very much. So that was part of what I said I was going to add. For the past couple of years, WHO was working on the development of a critical care course and then a sepsis learning pathway. That course has been completed. I'm glad to say that I was part of contributing to that course, and has been piloted already twice, one in Africa, in Liberia, and the other in Belize. The last pilot was in March this year in Belize. And that is actually targeted to what the question, the colleague who just asked the question. Because, I mean, for the burden of critical illness in our part of the world, we are basically dropping little in the ocean with just our specialty training programs. It is important to persevere with our specialty training program, and especially to train people who can train the lower cadre. But of that and the essential emergency and critical care, which there is a course being finalized at the moment, is actually to target not just the high level physicians, fellows, but targeting the nurses, the medical officers, the clinical officers who work in the ward, basically giving them the knowledge, the know-how, and then the resources that are in their environment for identifying critical illness. Majority of these patients, when they are identified early, does not need to come to us in the ICU. So where has this been piloted? So there has been massive piloting in Tanzania and Kenya. The World Bank Group has done a scoping review of which myself and Tim Baker supervised one of our colleagues, Daniel Soti, to do for Ghana for the availability and feasibility of EECC in Ghana, and that was repeated in 8 African countries. As I mentioned, in the last World Federation of Societies of Anesthesiology meeting, there was a side meeting on EECC, and there is a panel discussion on EECC in South Africa in the All African Anesthesiology meeting. So it is ramping up. And the reason is because of this is very pragmatic and it is easier to implement. But it is one of the tools in the armament. It is not competing with our residency training, because it is not a residency training. It is just making sure that our nurses are able to be more competent in identifying patients who are critically ill early. In the same way, the Global Sepsis Alliance Surviving Sepsis campaign insists that we should identify patients who are septic early. So we believe that with interventions like this, it gives us the opportunity to actually start building even that interest and motivation as people see the effect of their intervention for their patients. They would actually be motivated to go the extra mile or even going into critical care programs. Thank you.
Hello.
Hi, please go ahead and ask your question.
Yes, please. Thank you very much for the opportunity. I must say that, in fact, I have really learned a lot from the presentations that has been done. And I recently came out as an emergency nurse specialist, and I have so many worries, so many things bothers me practically working on the ground. And I was happy when Dr. Christian was presenting, coming to the final end of the presentation, where he talked on the EECC concept and emphasized that we are training resources, but we need the resources, and we need other factors to also help them work in the system, like the infrastructure, the telemedicine, the technologies, and other things. And I perfectly agree with him, because I have realized that at the emergency, even on the wards, there are times you pick cases that are critically ill. But to be frank with you, the resources to even help are not there. I realize at the emergency, a lot of patients are even recently coming with a lot of hyperglycemic crisis. A lot of malaria cases are even coming with cerebral malaria. But sometimes how to pick the conditions, the point of care equipment to use to even pick these simple conditions that usually people delay and they come in critically periods are not there, and which is very pathetic. There are times you have to even refer a case that you think if the resources are there, you could have managed it. You could have, example, like this DKA thing, which I'm passionate about. There are clear-cut protocols, yet in our emergency system, in our hospital facilities, how the early diagnosis of DKA is even a problem up till now. We know that we need this point of care equipment, like the ketone check kits. How many hospitals have these ketone check kits? I don't even at tertiary hospitals that I worked, I didn't even see this. We are still using urine dipstick, which we all know that when you are managing DKA, they come in levels. And sometimes at a level you may not be able to manage. You need to refer for critical care. Yet we are not even able to have that resources, like the potassium. You want to check your electrolytes and the lab will take 3 days, 4 days, 5 days. Results are not in. Yet you are giving insulin to these patients on the ward. And we end up worsening their conditions. And you have people even dying from non-hard DKA. How? So the resources now, they are training us. We are coming out. The knowledge is there. But sometimes things to work with, things to help you to really pick the cases, they are not there. And I think something should be done about it. I personally would be grateful if something can be done to bring these potassium check kits into our system, the serum pH level check kits into our system, because our labs are delaying and we find it difficult to make early diagnosis of certain critical ill conditions, which we can manage at our level. So I pray that this opportunity that I have gotten to speak my mind, stakeholders will take it up. If there is a way you can let us have, especially I'm on this DKA case, if we can get how the potassium kits in our system to use, please, authorities should take it up and make it available so that even at the district levels, we will start doing the early diagnosis and the early quality management of these cases. Thank you very much.
As Dr. Kilba highlighted, as the universal healthcare policies are developed, I'm sure some of these things will all fall in there. Yes, you highlight an important fact that we need a full spectrum of care delivery, and the WHO has recognized that by making it part of the universal healthcare package, and with that, hopefully it will trickle down and get to everybody at the front line. Thank you.
So, Nana, let me just add something to what you just said, because again, we are very good at drawing up documents, not so very good at implementing and then pushing our advocacy. And that is probably what a number of acute care advocates, both in the continent and then with colleagues outside the continent, are pushing for now. This is not going to come from top down, from the politicians, or from, it's going to take us, those of us in the critical care space, to fight for it. I am happy Prof. Aniteye and a few of our colleagues were with the national health insurance in our country, where they were looking at pricing. And among the things that came up is critical care, which has never been covered by our national health insurance. But they were asked to look at
I think we may have temporarily lost Dr. Wu there.
Yeah.
Yeah, Nana, we have Dr. Wolf and Joe Boache's hands up.
Yeah. This is Dr. Wolf. Okay. I have two things. The first question would have gone to Chris. I want to find out how the exodus of nurses is affecting this training of nurses that they are doing, because it is a very good thing for them to train people who can recognize, critical incidents very early and reduce transfer to ICU. And then also, I want to ask whether when they are going, they give them protocols for them to use in their areas of work. And lastly, to the lady who just spoke, I can tell the passion and, more importantly, the frustration in her voice. But she should keep persevering, because some of us have been doing it for over 25 years. And things have changed a little bit. Not half as fast as we wanted to change, but there have been improvements. I mean, at first, we didn't even have blood gas machines, and those things were theoretical things. There's only one in the entire hospital, and wherever you are, you have to run to this place, be carrying ice and stuff all over the place. But it's changing, but not fast enough. But my worry is, after taking them through all of this lady, if she gets a chance outside, will leave because of the frustration that you can tell in her voice. How has the exodus affected the numbers that you have trained? And then do we give them policies to take back to their hospitals? Yes, those are my two questions for you, Chris.
So, and I'm sure Prof also has contribution to that answer. So a lot of our nurses, and Prof mentions about 70% of our recently trained critical care nurses have left our country.
Yeah.
Actually, Prof, it is bigger than 70% at the moment.
Yeah, I think so.
Yes,
the data I had was 2023.
Yes, and as we speak now, and that is the partly economic drive, as well as the basically being left with a situation where you're trained and you cannot actualize the potential that you've been given. That is why the issue about critical care is not purely a clinical issue, but also when I mention advocacy, when I mention that it cuts across the different political, it cuts across health security and all that. So we would have to also, yes, we're not going to be the ones who are going to solve the political problems or the economic problems, so to speak. But in our, what lies in our hand is making sure that people, as we train them, at least are able to actualize. A lot of us, and Dr. Wolf, just like yourself, who are trained, and we've all had opportunity. Prof. Aniteye had the opportunity, he came back. We all went to train, we all came back. And we believe that we should be able to not only utilize even the knowledge of those who are here, but also the knowledge of our colleagues. Nana is joining us on this. And Nana has been a good advocate with some of us. Some of my colleagues are in UK at the moment and Northern America, but they are impacting back here very, very positively, either through training or through outreaching. And I mentioned critical care outreaching. And critical care outreaching does not only have to be from Accra and Kumasi to the regions, but it could also be very structured, very productive critical care outreaching coordinated through bodies like the Critical Care Society of Ghana and other bodies to specific places to train people. As people, we'll never lose everybody. Yes, we'll keep having people who will move out, but those who are left, what the quality should be good enough for those who are down here. And that is what we from the Critical Care Society are trying to push from this, that this is just this is basically like a launch of our society to say that, yes, we're coming on board, but we are not coming on board to have a society of intensive care physicians or a society of just intensivists, but a society that basically brings on board, and Dr. Wolf, you asked that question earlier on, everybody who is in the critical care space and gives opportunity, even those who are managing critically ill patients in the general wards, in the emergency rooms, to be part of the solution to critical illness burden in our part of the world. Thank you.
Hi. I don't know if you can hear me, but I want to commend you guys for what you are doing. My name is Joe Boache. I am a trauma critical care surgeon at the University of Michigan here in Ann Arbor. And actually a friend of mine, Dr. Dean at Collegewood Teaching Hospital, somehow sent me an email with this webinar. So I decided to log on. He and I had a conversation when he visited Ann Arbor, and I told him about my interest, in critical care in Ghana and the hope to come back. Now, my question to you guys is, are there areas for somebody like me who's trained in the United States, but still passionate, about Ghana and wants to come back to help? I can take a sabbatical a month or two and come back. Are there areas, and how can I fit in the existing system and models in Ghana to help out?
So let me again speak through the lens of the Critical Care Society of Ghana, and then a few things we've put in place collaboratively. So the first thing I want to say is that, Joe, you are very welcome. We are very welcoming to our colleagues in Northern America, in Europe, in Asia, who would want to positively impact on both training and then the care of the critically ill in Ghana and, of course, in other Sub-Saharan African countries. As we speak now, we have a tutorial series for our fellows in training that started off from Kumasi Confanoche Teaching Hospital, which those of us who train them in the different centers have come to agreement that all our fellows should be part of that. And we are welcoming colleagues who want to support some of this training. Alongside that, we have a program that is just starting off next month. Actually, our first meeting is going to be next week through the platform of the Global Health and then the platform of Johns Hopkins, which is coordinating a lecture series every single week for the near future from between trainees in Ghana and Ethiopia, with support from not just local facilitators, but international facilitators. I am coordinating the Ghana part. My colleague Mambo is coordinating Ethiopia. And one of the things we are going to do very, very soon is to put out information. A number of your colleagues in Northern America has reached out to me already to say that they would want to be part of this series. We do not want it to only be lectures, so we are also looking at other methodologies of training that would be impactful clinically. But yes, we'll be reaching out to a lot of you to ask for your preparedness to support the training of our fellows. But that is even at the fellowship level. Then the issue about lower down, because that is extremely important, and I am extremely passionate about that. But we want to be able to set up a big group of like-minded people who want to train residents, but also want to help train those who are managing critically ill patients in the world. I know the pediatric intensive care units have a similar arrangement in Kolibuchi Hospital. A few of the people that support their training are actually some of my colleagues in Northern America. So yes, we have a very big open door. We are going to be extremely welcoming to our colleagues who are in the diaspora in both supporting training and also supporting the care of our patients. Thank you.
Yeah.
Yes, Joe.
Sorry, Dana. Yeah. So just to add to that, yeah. So Joe, you don't need to relocate to come and stay here completely to have an impact. So let me give you a typical example. I have a mate of mine, schooled here in KNUST. Did pulmonology in the US and specialized in critical care. So recently she was coming to join the old student, Wesley Girls old student homecoming for about 2 weeks in Ghana. And she was going to be in Kumasi. I grabbed her. We had bought some bronchoscopy in the ICU. We couldn't do diagnostic ICU bronchoscopy. So I arranged with her for the period that she came. She came to train a few of the specialists in critical care bronchoscopy hands-on, and it's been very beneficial. Subsequently, a lot of ICU patients who need bronchoscopy, we are now doing it such that we are even now about to organize some training for the specialists who couldn't participate in her training. So we want impartation of some skills that we lack, and those are the things. Once you are ready, we collaborate. The skill sets that we lack, when you have a 1 week or a few days, we organize, you train the trainers, and then we impact. So there are different models. Just let us know. Thank you.
Thank you all very much for this lively discussion. Unfortunately, sometimes when you're having fun, time flies, and we are at that point. This is the beginning of conversation. So let's not this be the end. I'm sure with the names of panelists here, you can find everybody on LinkedIn or some other social media platform. Conversations can continue to go on, and we will meet in other areas to continue this conversation. We all focus on improving critical care delivery on the continent, and as we work, we would definitely interact with each other. Thank you all very much for your time. The recording will be made available for a future viewing, and sharing with others and also for sharing across social media by our colleagues at Oxford. Thank you very much for your time, and any other questions that have not been answered, we will try and collate them and respond to them in writing.
Thank you.
Thank you.
Thank
Thank you
you.
very much.
Bye-bye.
Bye.
Cheers all. Well done. Thank you.